because that was the third shutdown I think we've had.
Well, I'm gonna start recording because I think that we can start the conversation here. And as people come in, and I really hope that they do, we will let them in. But Mike, one of the things that Kendra had brought up is that the testing, how, you know, COVID had basically ran through the agency, and, you know, all of these folks had got their test results, had caught COVID really before they were even able to wrap their hands around, you know, getting the first test to see what folks' status was. And that's one of the things that comes up, especially in the substance abuse space. I know in my practice, where, you know, I'm the director of addiction services, you know, we look at room size in New York State. So in New York State, the room size could be, prior to COVID, 15 people in the room. So now it's about real estate, how much space you have and how much circulation there is in that space. So what we did was we took our room size down in terms of participants from 15 to 12. So we thought that 12 was
he started saying something about leases in Alaska today. A little shut up.
a lot of background there, Mike. I think that's you.
That's on my house. Be able to push this electric.
Or Chris, let me, oh yeah. So what we did was we said, okay, we did get guidance from the New York State Office of Substance Abuse Support that said, you know, we can determine our room size. They want the room size to be safe. So we said, well, okay, we'll keep it at 8 and we'll see how the circulation goes. But then Omicron came into play. And it just seems like those 8 people that was in the room, 4 of them tested positive within, you know, a day or two. So they had described one of the participants to me. They said, well, you know, when he came in, his nose was running, his eyes looked like they was red, like he was, you know, sick. And I'm like, well, how did this person get past the thermometer downstairs, the forehead reader, and we have a thermometer downstairs. So, you know, I didn't know if whether or not the people at the front desk was paying attention to people that's coming through the door, because that's supposed to be the first line of defense. So when we're looking at this thing, we have to look at what's in place. And the first line of defense is the thermometers, and whether or not people, when they sign in, you know, they're showing any type of symptomology. If the temperature reader goes off, then is the front line person or the desk person asking the person to, you know, just hold on for a minute and, you know, ask them if they're all right, do they need to see someone, that kind of situation, not just think that the equipment is malfunctioning. You know, so that's one way of looking at it. And then the other way of looking at it is, how can we afford to test? Because right now we're looking at urinalysis and we're testing people once or twice a week with urinalysis. But COVID seems to be a different testing scenario, because it implies, or it has an impact on whether or not your doors stay open. You know, testing for urinalysis don't have that direct impact. So how do we get access to reliable, affordable testing? And what should be the testing protocol? You know, should we test people within a 72-hour window, Monday, Wednesday, and Friday, with a reliable lab that could have us a test result back within a 24-hour period of time? So that way we could have information, actionable information about a person's status within 24 hours. And if we're testing them at a 72-hour rate, then we will know whether or not, you know, the next time this person comes to attend treatment or to attend some type of service, we would have access to the person's test results. What you think about that, Mike?
I completely agree, because I mean, it's one thing to have your policy mean, policy is only so good until it has to be implemented, right? And then you see everybody's eyes roll back because it's too much or it doesn't work. And then the reality is this is what we're going to do versus this is what is happening. And I think it's the easiest way of saying it is how do you keep your doors open? You know, because if everyone's sick and no one's there, no one's getting treatment, then the dominoes start to affect. And if they're not getting treatment or not getting counseling, they're going to be back in jail. And then it's just a lot of things can go wrong just for the fact that they're not there. And our whole philosophy at Beechtree was when you see a problem, how do you fix it? Right. I mean, that's Thurman, you've been out to the lab. And but it's no matter what you say or what you sell, it's what's really happening. And I think if anybody's gone and got COVID testing lately, that they want to forget about the last experience they went and got COVID tested. Okay. And I mean, my sister-in-law literally sat in line for 3.5 hours with 2 babies to get tested. And then she was told her results might get back in 7 days. And this is her daycare is based on that. Right. And so there's so many problems that we've just basically come up with a way to do what we do and to get turnaround times faster. And one of the reasons Chris is on this, Chris is our all-knowing guru about the ins and outs of the COVID world for the lab. But from a nurse's point of view and from the clinical education point of view of how to use these results, our whole concept is how do we make it simple? How do we make it easy so that you guys can do what you do? Because there's nothing worse than something happening very, very fast. And we even had a prison system in Alaska that said, hey, can we step in and help them? Because it was going so fast through the prison, they couldn't triage people fast enough. And Kendra, you mentioned that it happens so fast. What do you do? And I mean, I don't want to pretend we're Superman or anything like that, but I mean, the results get back fast enough to where you can actually make that decision or say, hey, let's not do group today. Let's actually do a telegroup and then sort it all out instead of everybody getting sick. And COVID is very, very real. There's different variations of it depending on what variant you get, but nonetheless, I mean, it affects everything. And the fear that comes with being positive sometimes is worse than, or I'm sorry, the fear of not knowing if you're positive is worse than actually getting it. And so our whole thing is let's get a test, but then let's make it to where it doesn't bog you down with the information, because the only thing that's worse than a positive result is making sure everybody gets the information and not putting it on the therapist or the provider to then get all that information out to the right people. We've got a seamless way of doing all that through an automated application. And so that's our whole philosophy is how do we just make it actually clinically useful instead of one more thing you have to do, one more thing you have to worry about. That's kind of our approach with it.
So that automated system, go ahead, Kendra, go ahead.
No, I just was saying that is appreciated if we don't have to be the one to make sure that every step happens. Like one more email to send off to one more person, to send off to one more person, and so forth.
Yeah. And then it all goes bad when no one trusts the results. Have you had one of those tests where it's like, I'm positive, but am I really positive? Or is it negative? Do I need to test it again because I don't believe the results? And
so we, because we couldn't get a hold of testing, we just grabbed some Walmart rapid tests at some point. So we had something to go off of. And that did happen. Like one of them was faint and you're like, so they're not symptomatic, but that is a line. But what do we do?
Yeah. Our whole philosophy is get the right test, get the right information, and then you can do something with it because it's clinically sound. Yeah. Versus I hope I did it right and I hope the result is right. And so basically, if we say you're positive, you're spreading it. That's it. If you're negative, keep going. You're not spreading it right now. Yeah. And so does that answer your question, Thurman?
Yeah, no, it's just informational. And from what I understand, the Beechtree also targets 4 of the SARS genes, correct?
Correct. Well, there's 3 specific things we're looking for in the COVID gene, but then we also have an identifier to make sure that there's enough of a human sample that it's a legit sample. Because a lot of people will wave it in the air and then put it in and say negative so that they can continue on with life because they don't want to be positive. And so one of the things that we test for, there's 4 things that we test for, but one of them in particular is there enough of a human sample to say this is a valid test? And then other than that, yeah, we're looking for 3 specific things instead of one target thing. A lot of these rapid tests are just looking for one target. And we were looking for 3 specific targets on the COVID.
So there's that validity. This got to be a human sample. And then we're looking for the other 3 specific COVID genes. And because I saw one of the scientists said that, if you test positive for those 3 genes, you're basically, positive.
Yeah, you stay home.
Yeah, he's in.
Or you telehealth in, stuff like that.
Mhm.
So, Chris, am I missing anything on that? Chris used to have an amazing view of the Wasatch Mountains until they built a building behind his office. Now it's this cement building behind him.
Uh-oh.
And so,
No, but one of the other things about COVID testing in New York State, they have the Department of Health. They published this. It's called Wadsworth, and it's where New York State gives a weekly publication on laboratories that have an excess capacity to do testing, and their testing turnaround is less than 4 days. So we were really looking at, how do you keep the Empire State moving? Because there's a lot of hustle and bustle in New York. How do you keep the doors open? How do you keep our venues open with a less than 4-day testing turnaround rate? It's not an acceptable protocol.
well, I think anywhere is that. I mean, because clinically, when you talk about it, even Kendra, when you have your group, and or Marty, when you're talking about recidivism, right? Like, how do you make sure that person can actually get in front of where they need to be without it all being canceled because of the possibility of a test? And even Thurman, when we were at that conference back in DC, how many people are not going to see the judge to plead their case or to talk to their parole officer because they're positive or they're negative? And there's so many. I mean, I heard earlier today that it's like playing a Rubik's Cube. Right now, the clinical world, it's like playing with the Rubik's Cube that keeps changing colors. Because as soon as you think you got the white, it changes. And then as soon as you think you got the yellow, it changes. And all of us are dealing with that. And so the whole concept that we have, the only thing that we can't control is shipping. And shipping is an absolute cluster right now. Everywhere. I mean, we are getting today, our lab is in Salt Lake. We have 1 lab in Salt Lake City, and we have 1 lab in Anchorage, Alaska. And we have packages arriving that say next day priority shipping, guaranteed next day shipping, 4 or 5 days later. And so it's hard to control that, but once it's the lab, then the turnaround time is that much faster. So we have a 24-hour turnaround time once it gets to the lab. The thing that actually makes it unique, and what we'll do is when Chris gets back on, he can share the whole thing. But the biggest thing that we do is each person, and Kendra, you would appreciate this, okay? There's a QR code that we generate for each location. So your facility, or Chris, correct me if I'm wrong, okay?
I'm sorry, I heard my name.
This is the quick Chris speak, okay?
Did you
This
want
is
me
clinician
to
to clinician.
share that process?
Actually, yeah, why don't you just go ahead and explain that? Because this thing right here, if you can see this is me saying it's orange and I need to test again because I'm past my 72 hours. So we have a system that actually thinks for you. So you don't have to say, oh, let me go back and check your records. When were you tested last? It works. And so we've tried to make this to where all you got to do is look at their personal pass and you'll know exactly where they are. And Chris can show this stuff. And Chris, we're actually recording this so Thurman can share this with the other.
Perfect. Thurman, can you allow me to share my screen?
Yes, let me make you a host. Let me 1 second here. Chris. More. All right, Chris, you are co-host.
There we go. Now, why can I not see? Oh, there we go. That's what I wanted. All right, hopefully everyone can see a screen covered in green.
Yes.
All right, cool, excellent. This is our deck. I'm happy to share this afterwards. I know you've talked about a lot of it, but I really wanted to just sort of spin down to the process. But just very quickly, I know you've covered a bit of this already, but really our three key differentiators, and this is true of all of our labs, we've always focused on the highest quality science. And I'm sure Mike said about the 4-gene test, we have a single gene that looks for a sufficient sample, so you get rid of the false negatives, and we're looking for 3 genes within the coronavirus. So when we say you're positive, we can say so with a very high percentage of 99.99%. The second one is turnaround time. A lot of labs have struggled with capacity during particularly the Delta and then subsequently the Omicron surges. We built our first COVID lab in our lab in Alaska, and it was really important that we were able to deliver fast turnaround time because the fishing fleet, the oil industry, was so dependent on fast turnaround time, and so we guaranteed the state of Alaska that we would do it in less than 24 hours, and we average 6 hours. And the way we do that is we built for far more capacity than we a day in each of our labs, and we're nowhere near that level of capacity, and we never anticipated to be there. We did it because we knew it was the only way to guarantee the turnaround time. And then the third thing is the process we've made really efficient through a technology application that Mike was just talking about. And really the key thing there is it makes the process at the front end of collection, the sample collection, really efficient. So that saves time and money at the front end, and makes the process very easy for the patient. And then it saves a lot of time at the back end because we fully automated the reporting to the patient, the reporting to the provider, and the reporting to state and federal as well. Let me just flick through. There's a lot of stuff here. I'm more than happy to share this with you afterwards. But this is the slide I wanted to talk to. So the process is very efficient. The software platform we use is Remedy. So it's Beechtree powered by Remedy. You register using a QR code on your phone, which if you're in a sort of clinic setting, it can be done. You can register ahead of time. It can be emailed out to a patient. They can scan it when they're in the waiting room and register before they come up for their test. Or if it's in a drive-through or school type setting, then they can register while they're in the line waiting to get the front. So by the time you get to the front, you don't have a bottleneck. The process is very efficient once you get to the front. So once you're registered, you get a QR code on your phone, and you can save that into your Apple Wallet. Once you're registered, you only need to register once. So for example, if you come back to another to come back for a test the following week, you don't have to go through the registration process. You're registered once and that's it, you're in the system. When you test, it just asks you if any of your symptoms have changed, and then you're ready to go. The person who's administering the test, and we can do nasal anterior nares, no need for the deep nasal pharyngeal anymore unless you really want to do that, and nobody does, or saliva. And then we have a QR code on the test kit itself. And so the person who's administering the test scans the test kit, and then they scan the patient, not the patient themselves, but the QR code on the phone. And then the test kit and the patient are then linked together forever. The test is administered, name and date of birth is written on the tube, which we have to have 2 personal identifiers on the tube. And then it's sent off to the lab. We provide all the packaging, all of the shipping labels and everything. It arrives at the lab, and then it runs through the test process. When it arrives at when it's resulted out by one of our scientists, then it's fully automated in terms of the reporting. So the patient will get to their phone, both the health pass, which this is the thing that Mike was showing you. It shows, and this is kind of used for travel and events and restaurants and things like that in New York. The green means that you are negative within the last 72 hours, and that's because the travel timeline is 72 hours. Amber means you're negative, but you haven't tested in the last 72 hours, and red means you're positive, you should isolate. There's a dashboard, which I'll show you in a sec. And then there's also a PDF. You also get the PDF report, which you need for travel and things like that as well. And then this is just some of the questions in the registration process. But here's the dashboard. So you, as a provider, you would get the dashboard, which shows you how many tests you've done, how many you've administered, where they are in the process, whether they're still being processed in the lab or whether they've been resulted, positive, negative, and then obviously all of the data behind this as well for your patients. It's a web application, so it's fully HIPAA compliant, and also we do testing for the US Navy, so we've also got a fully DoD compliant approval for our platform as well. We have a separate instance for the DoD. So that was a bit of a whirlwind through. Happy to answer any questions or go into any more detail if that would be helpful.
So that works great for our outpatient clients. For resident clients who are not allowed to have like an electronic device, is this something like, would we just store a QR code on hand for them? How would we do that?
Oh yeah, so we do a lot of homeless shelters, care homes, and schools where they don't have it. You know, the little kids don't have it as well. It's another good use case. So in that scenario, we provide tablets, and you have a tablet on the station, and so when the patient's QR code can just be scanned from the tablet, or if they need to register themselves, then we give you a tablet to either the patient can register themselves, or in some settings they need help. So you may need to have a professional on hand to just help the patient navigate some of the questions. But we can do it all like that as well, and that works just as well. Yeah, and with schools, we've even gone as far as little laminated versions of the QR code that they attach to their backpacks. So when the little preschoolers and stuff like that, and that works too. Yeah.
So if I was an agency, a substance abuse agency, and I already have a toxicology system in place, and I would be interested in saying, okay, well, could my clinicians or my staff members, do a test on the client as if it was a toxicology test and have that same access to the automation that would give me the feedback on the client's test results?
Yeah, we have that for our talks. I'll let Mike talk to this a bit more, but we have the same, and it's not the exact same software, it's a different platform for toxicology, although interestingly, this particular one we're building out to try and do the similar idea for tox, but we have a fully automated portal for toxicology reporting as well, so our providers have direct access to the reports for their providers. Some big providers we have directly integrated into so that we send the data automatically into their EMR, but most providers access through our portal. Yeah, so they have electronic access for all our clients too.
And the nice thing about this too is we just try and make it work with whoever's there. I mean, some places like residential places will include a QR code in part of their med book or part of their med pass, so everything's there. I mean, you think you do these things all the time, so what's the easiest for you? And sometimes when we go in and do the tests, they'll literally pull the MAR out and scan. I mean, the hardest part, like what Chris said, is getting started, getting that personal QR code. But if they don't have the phone, or if they don't have access to it, then all you got to do is put their specific code in their specific wherever spot you want to put it. And then when it comes time to test, like what Chris said, we'll provide the tablets, and it's literally scan that QR code for that person, the QR code on the tube, confirm that, the information, that the questions that they ask clinically is, for instance, it would say, if I was being tested, is there a 47-year-old male in front of you? Yep, that's it. Then it goes. The nice thing about it too, clinically speaking, it's always a nightmare to keep track of records. What's where the results can be coming. The nice thing about this is the system is designed that as soon as you scan it, an email or a text will be sent to whatever information got set up. So you'll know it got started, it's been activated. Once it gets to the lab and is scanned in, another email comes across saying, hey, my test is actually at the lab being activated. So it's not this lull of wondering where is it and how long is it going to be. And like when Chris mentioned as well, as soon as the result is done, it doesn't go, it goes to wherever it's set up. So not every single person will set it up. So in like residential facilities or thermal, you're talking about programs, those program managers or case managers decide how the information is disseminated. So it won't just go wherever that one person wants to go. If it's a program, it will go to the place that it needs to go. And when the results,
I can show you here, you can see. Yeah. So, oh, let's close that. I got mine. We get tested all the time, obviously, we make sure we keep our scientists safe. But This one says your QR code has been used to initiate a test. So I'm ready to go on the test, and then the next one I get back is my health passport, which I can then click on and it gives me my health passport, and then the final one I get back is my test result, and that tells me.
And those come in either a PDF to put in your record or your personal QR code on the phone. And all of it is organized in a way to where basically you can say, hey, how can we help you in whatever system you have? But we don't come in with the hammer and say, we're the biggest lab in the world, you do it our way. I mean, that's not how we've designed this. It's really caters to the individual needs. And we've done it from a clinical point of view. So hopefully we don't make your life hell on earth.
So Mike, if I may ask, those adults who are incarcerated, you provide a tablet for the procedure?
Yep. Yeah. When we've done the prisons in, like, for instance, in Alaska, we show up and we provide them with everything so they keep track of it and test.
So each inmate has his or her own tablet?
Whoever's doing the testing has the tablet.
Okay.
But each person that is being tested has an individual QR code that is stored by either the nurse or whatever that facility has.
Thank you.
And in the context of the criminal justice system and these tests, for instance, like court systems are struggling with due process, having guys come to court and really having their proceedings, move forward because of COVID and the fear of folks becoming positive. So how would the test, or how would testing with Beechtree help the court manage its docket? Because the court has this huge docket where they are scheduling people to come to court, but because of COVID-19, they don't know how to tell the jailers who to bring and who not to bring. They don't know how to sort things out yet. How would Beechtree help those kind of systems? Because on Rikers Island, you have 10,000 inmates on Rikers Island who are waiting in pretrial detention. So you look at that large population and you say to yourself, okay, Your Honor, there's a liberty interest. Folks have a right to due process. So we want to be able to get them to court, get them to be able to see their lawyers. We want to get them in front of the judge. So we want to use testing to help you manage your docket, where you could know if a person in pretrial detainee status, whether or not they're positive or negative within that 72-hour window. Can you speak to that, Mike? Or Chris?
Chris, do you have any immediate thoughts on that? Because I mean, we work with court systems, industry, providers. The thing that we found the most, and correct me if I'm wrong, Chris, but when there are no options, there are no options, and no one knows what to do. And the biggest thing that we found is by saying, here's our solution, here's our turnaround time, here's our app, how can you use it? We see it be used in a lot of different ways. I mean, we literally had a conversation the night before with the VP of one of the biggest oil companies in the world. And we basically said, you got a great COVID plan. Here's our plan B. And guess what happened when that COVID plan went to crap? We suddenly became their testing solution the next week. And there's a lot more options available when you have guaranteed turnaround times, an app that actually works with the system that can be shared. Because as soon as a provider can turn around, or not a provider, say Rikers Island, did I say that right? Rikers?
Yeah, Rikers Island.
Rikers, okay. If you have that many people sitting waiting for results, you think about the domino effect that happens. Well, if they're positive or negative, they're not going to be taken out because the person transferring them, the lawyers, the judges, everybody else doesn't know what's going on. But if you can turn around and say, hey, we know what's going on, these people are negative, they deserve all the due process. Everyone deserves all these rights, but when no one knows what's going on, everyone's on a holding pattern. That holding pattern gets worse and worse when there's an outbreak, because now no one knows what's going on, so everyone just waits. And Chris has been hilarious because we found all these different solutions by getting better information on a timely manner that's easily duplicatable. And so, I mean, even like the fishing industry, I know it's different than prison, okay? But do you want to go over what happened with Knick-Knack? that little fishing fleet
Back
story.
then, yeah,
It's
exactly.
crazy.
So I think that I mean, Mike mentioned it earlier on, which is that the nice thing about us being a boutique lab is we can be very flexible in terms of the way we set things up. The Remedy application actually gives us a lot of flexibility. We also have direct portal access to our lab information system, and we also integrate using our technology team into different systems. So depending on the scenario, and I'm going to use the fishing industry as an example, as Mike mentioned, with one of our big medical companies that supports the fishing industry, we just send them the data directly. They don't have individual fishermen, logging in. It's all done through the healthcare company setup, and that's separate. So in that prison scenario, that might be a better way of doing it rather than individual QR codes. There's different flexibility. The QR code thing is brilliant for, schools, drive-through sites, anything where you're talking about high volume testing. It could be very good in that instance as well, but there's also a way to connect data directly, because in a prison system you might be in a slightly different scenario, and that's fine. The situation that Mike's talking about, there's a small village in Western Alaska called Naknek, which has the biggest salmon run in the world. And there's only 200 people that live there. We went and sat with the mayor, who also is the guy that looks after the boatyard with 2,000 boats in it. And every June, 64 million salmon run up that river, and they catch tens of millions of salmon. 2,000 boats hit the water, and 20,000 people land on the ground, and they all needed COVID testing to keep the fishing fleet alive. Because if they get locked down, the state said that if you have an outbreak, we will shut you down. And of course, their season is 4 weeks long. So if they get shut down for 2 weeks, they lose, nearly 70% of their revenue. So for them, it was just a no-brainer. They had to test, and they had to have a really good, really robust program.
Yeah, because in my mind, I'm looking at actionable tests. How do we look at our systems, whether that system is that fishing boat scenario, whether it's a prison system, a court system. We have venues where, people are in Las Vegas, people used to congregate together to have these conferences. I mean, these are scenarios where folks could set in place a testing protocol that would allow us to continue to have our events. We will be able to know ahead of time what a person's status is 24 hours before they even come up in whatever venue that is playing at that time. We'll be able to have actionable information that's protected, not given away to anybody, not dispersed out to all of these different other vendors, but just really a place where information can be accessed in terms of folks coming in. If I own the MGM, I want to know that the person that just walked through my door to see, the Lion King has a PCR code within the last 24 hours that says negative. Or if that PCR code says, hey, it's an orange color, and I'll say to the person, hey, you ain't been tested in the last 72 hours. Yeah. You need to get tested. See, I will have information that would help me to sort things out.
The biggest thing that we've done, like what Chris said, is we're very flexible, and the solution that we have, we don't have an application or a setup thing that's a one size fits all. We come out and see what's going on, and if it's an outpatient program, inpatient program, the MGM, I mean, we're doing concerts, we're doing entire fishing fleets. I mean, how many naval bases are we doing with, military coming and going on? We're the lab. And we came up with a solution that basically says, hey, we'll get you going faster. We'll get your results faster, and you can trust them. It's really what it boils down to. And then everybody else can use the results in whatever way to actually disseminate it out. And so the thing that we're most interested in is that the science isn't based on a supply chain management that we run out of inventory. And the other thing is, how do we get it to where you guys can actually say, if it's positive, just like our drug testing, this is what this means. And it's just being able to trust the lab again, because there's so much confusion going on right now, not in the CDC or politics or anything else. If it's positive, what does that mean? If it's negative, what does that mean? And if it's really negative, is it negative? Can I move on with my life? And that's the thing that we've just strived, is to be the best lab we can in a way that actually is usable versus waiting 7 days calling people for your results and actually getting your turnaround time.
I often think about New York as a place where we need test results in a more speedier way than the less than 4 days that is currently New York's established turnaround rate. I mean, you guys was thinking about coming to New York. What can you bring to New York, the Empire State, in terms of testing here? Because folks from New York is going to see this video.
The biggest thing that we're doing right now is our whole thing is to make it to where you get the same results no matter what, right? And whether it's a rural little town, East, West Coast, as long as we have the shipping problems or we don't have shipping problems, our turnaround time is 24 hours. And the biggest thing that we're looking at right now is we want to be the best lab we can be. Chris is our absolute COVID guru guy. We love partnering with groups that do the collection side. We want to be the lab. And as far as the temporary license in New York, and even coming to New York and building a lab there, the whole point is the turnaround time. Because if you don't have the turnaround time, it doesn't matter. I mean, the worst thing possible is to sit in the airport and wait for your lab results so you can get in through TSA. I don't know if you've experienced that yet, or if you're waiting for something. And so, but it's one thing to say you're this, but it's another thing to actually scan a code and be done and move on with your life. And in Utah, we're not New York, right? But in Utah right now, there's an average to 3 to 4 hours for a COVID test. 3 to 4 hours. I don't get that. And then a 7-day turnaround time. And so two locations just opened up and put it on Facebook and said there's no wait. And that location went from doing, I think, 100 tests a day to about 700 tests a day, that fast. And word spreads fast. If it works, it works. If it doesn't work, it spreads fast too. And luckily our reputation right now is that we do what we say. And as far as New York in particular, as soon as we get that temporary license, a lot of us are flying to New York to start setting up lab testing.
Yeah,
So,
I know when you was up in New York a couple of months ago and we was trying to get in the restaurant, and I'm fully vaccinated, and you had a PCR result and they was like, no, you can't come in.
I was a leper.
Yeah.
Yeah. You were like,
yeah.
Yeah, I can say I was negative, and then that all comes down to, what state are you in, what city in, what time of day. But when we look at this and we just turn around and we say, hey, how are you going to see your people? Just like on your training on Saturday, how do you make sure that those people are coming? I mean, the other side of our business is toxicology. And when you see the true number of people that are non-compliant with their mental health medications or with their other medications, that's the reason we're having all of these problems, is because people are self-medicating. They're not following through, and people don't realize that when they take the wrong med or the wrong time, or they switch meds, they have all these problems in life. And it's a lot of the reasons that people are committing crimes or are doing things wrong is because medications are in their system. And none of that is able to be addressed because COVID is so loud right now that people aren't going to get the treatment they need. And so we have a two-pronged approach with this. Number one, we want to help people get better through our toxicology, but they got to be able to get treatment. And that's the entire reason we got into COVID, is to make it to where people can get back and get into treatment.
Yeah, because I know our new mayor, Mayor Adams, they are interested in figuring out how to do more testing in New York. I mean, set these things up. So, and Governor Holcomb just signed the disaster relief declaration on the 31st, I believe it was. And so they are interested in doing testing. I just would like to see you guys get the opportunity to show New Yorkers what you can do, because New Yorkers deserve a standard of testing that would allow, and the whole country, I mean, really countrywide, nationally, the nation deserves a less than 24-hour test. So in order to get there, we're gonna have to figure out how folks could really partner up with people to help make this happen, because the only way we could really get to herd immunity or whatever we're trying to get to, because, we, on the one hand, I look at it this way. there is a public health concern with people who are not vaccinated. But I understand that people also have legitimate complaints about not being vaccinated. So the alternative, in my estimation, is Beechtree. Beechtree has COVID testing that could give us actionable results in real time. So we don't have to have our officers, our first line people resigning or being terminated from these positions when we have laboratory testing. That could be the alternative to all of that, because we got to get to a point in our country where we say, okay, look, the terminations and the resignations, okay, we're not doing that anymore. But we got to have something reliable as plan B. Less than 4 days is not a really reliable plan B. Less than 24 hours is getting towards a better plan B. So that's why I'm really interested in recording this kind of information and having this kind of exchange, because the word has to get out there that there is an alternative.
Yeah, there are options, and it's not necessarily, we love working with testing groups. I mean, Chris, again, everyone has questions about this. You put Chris's email on this, but we work with collection companies all across the country, but we also work with specific clinics or rehab places where they can do their own. We teach them how to do their own collection, so you don't have to send your people to go get tested. We can actually send somebody in to get your people tested. Or we could set it up in a way to where you guys can do the tests and ship them to us. So there's, again, we're not trying to come in with the hammer saying conform to our lab. We're basically saying we understand that there's a lot of problems, there's a lot of issues. Here's our solution. And one of the things that we've learned that Chris mentioned in all of these different locations and different things we've learned in COVID is that there's a huge difference between approaching COVID with a proactive solution than a reactive waiting in line. And that's what it seems like everyone's doing, is no one knows what to do, so they stand in line or they wait. And all we've basically said is, hey, here's a solution, go forward with it this way, and it works. Everyone goes forward saying, here's how we can use Beechtree's solution in your location. And we can fit that way. Not everywhere all the time, as soon as New York gives us that temporary license, we're there again. Okay, that's the only thing stopping us in New York right now. But as far as Utah, California, in Alaska, Arkansas, I can't remember how many states we're not in right now. But what we found is what we've done testing wise, app wise, solution wise, it's a very, very proactive way of approaching this. We just need to know how you want to use it, and we'll custom our results to you guys.
Would you sponsor testing sites at locations like Kendra and Laura?
Yeah, in fact, with Kendra's site, it's crazy. It's a lot of it's word of mouth too, because I think we drive past your place 2 or 3 times a day. In St. George, we've got samples from St. George coming up all the time, right? Mm-hmm. Laura, where are you based out of?
We're both in her.
Yeah, we're both in Cedar City, Utah.
Both in Cedar City?
Uh-huh.
Okay. Yeah, so depending on, we can have James or have one of our people come by, and really anybody, Thurman, that's interested in that, we can send somebody to talk with them. But it's coming down and saying, what's best for you? Do we need to send somebody in to help you out? Or do you guys have your process that you just start using our tools? That's, we basically just want to be a tool in your toolbox.
And I think it depends on how, is this, so does Medicaid pay for testing? How does testing get paid for? And then with that, is this something that Jen could be bringing with her when she does our drug tests? And how sensitive are the tests? So if somebody was exposed 2 days ago, will we know?
Chris, you still with us?
Are you talking, I know obviously we digressed a bit there into drug testing as well, you were saying, but you're talking about COVID testing.
I am talking about COVID.
So we're PCR tests, so our sensitivity and specificity are greater than 99%. So if you're carrying a viral load, we will detect it, and that viral load means that you are infectious, if that makes sense. There is always a period of time after you've been exposed, but before you are infected and spreading that you could. So if you got exposed today and you tested tomorrow, then you may be negative, but because you haven't actually started to develop the infection yourself, and it's usually a couple of days before you may develop that. PCR is going to pick it up the earliest. Antigen tests, it tends to be a little bit later, and that's why they recommend you do one and then another one a couple of days later. That's why they sell those at-home packs often in twos. But yeah, and then the same thing on the back end. You could test today, and then the viral load can drop off quite quickly towards the end. That's why you've noticed that the CDC's just changed its quarantine requirements from 10 days down to 5 days with a negative test. That's because that can drop off pretty quickly at the end, and you may not be infectious anymore, in which case you don't need to still be in quarantine.
Okay. And then is this something that Medicaid pays for? So we do have Beechtree come in and do our substance use testing.
Yeah, so for any individual diagnostic test, the CARES Act requires it to be covered. So it's covered by insurance or by government payers or state payers, if that's the case, like Medicaid, Medicare, or commercial insurance, and uninsured are also covered. So that's an interesting difference between, conventional medical billing where an uninsured person would not be covered. The CARES Act pays for uninsured, including undocumented. So anyone who comes in for a test, and you cannot turn down someone for a test, they will be paid for by one way or the other, and we do all of that billing. So it would be zero out-of-pocket cost, and we're not allowed to charge any kind of copay, any kind of bill. It has to be covered 100%.
Okay, and this seems like something our staff would be able to do too. So we could test the clients, have their QR code set up, but our staff would also be able to have access to tests, and we could just even mail those in.
Correct. Yeah, exactly. And also, if you're testing someone, the CARES Act split the testing program into two parts. So there's the technical component, which the lab does. So that's the actual test kit running the test in the lab. We bill for that. And then if you do insurance billing yourselves, you are actually entitled to bill for the collection or the visit that involved with the collection. And that pays $23, generally about that. Medicare pays $23 to cover your costs of administering the test as well.
Okay, and then like where this tied into the idea of substance abuse was just, is this something that it's Jen that comes in and typically does our testing? Is this a test that Jen can bring with her when she comes in to do our urinalysis tests?
Yes, absolutely.
Yep. We'll just make sure it's included that she knows to bring them.
That's as long as as long as she knows to bring them, then it's absolutely, yes, completely.
Okay.
Yeah, that's fantastic. Because I know that up in New York, there would be a lot of behavioral health clinics or integrated clinics who are basically, the doors are beginning to shut because there isn't enough testing, or we don't really know what individual status is. So to be on the safe side, everybody is running back to the remote way of engagement.
And it's also a nightmare to say you're a residential program with 20, however many people. Hey, everyone get on the bus. We're going to go get tested. And if anyone's positive, you're all going to get back on that bus and go back to the rehab.
Yeah.
It's just, the whole thing is a nightmare. So the whole concept of, can we come to you?
I concur.
It's more of a boutique way of us saying, hey, let us help you. It's just, it's amazing all this is even happening. But yeah, we don't want everyone just to come to us as a lab. We figured out ways of going to you guys.
Well, you know what I thought about it? When I look out my window, there's sort of like all of these, because I'm in New York City, so there's all of these buildings out, residential buildings. And I'm of the mind that says, what if we had a situation where, what if we had resources that we could place in each building or each residential place that has a certain amount of people in it, in their lobbies, to say to anyone who lived in the building, listen, you can go downstairs and get tested. And you can have your results, it's going to be automated. You can access your results on your phone. I mean, that would be the quicker way to really, in New York City, have people doing transportation, still wearing their masks, still washing their hands and doing all the rest of that. But you can really begin to sort things out. But that's going to require huge resources. but the resources, they're going to have to bring it to the table. It's just a question of who's going to, there's going to be a lot of competition.
Well, and with COVID right now, so many people are trying to boil the ocean and fix the problem that we basically said, here's how you can boil a pot. And this is our pot and our solution, whether it's a rural, small town, anywhere, anyhow, just it's a simple solution with a simple reporting system. And then one of the things that Chris, I don't know if it was, Chris mentioned it, but I don't know if you caught it. If any of our tests are positive, it's automatically uploaded to the state. So that's not on your shoulders as well. For any clinician or any program that has a positive test, you have to report that to the state. We automatically do that through the app. And so that's not on your shoulders of, oh crap, I have a positive, now what? It automatically happens. So you just deal with it clinically and we deal with the reporting side of it.
And how does it translate down through the facility? They have a person that's tested positive at Kendra's facility. How is that person then notified, and how do we address that person's symptomology or their possible contagion?
Yeah, what's interesting there is the application will automatically tell them that they're positive. And it recommends that they if they're positive, or it actually even says if you're negative and you've got symptoms, you should seek medical advice from your provider. Now, in this scenario, in Kendra's scenario, what you can also do is under the CARES Act, the provider can do a follow-up visit, and it can be done over telehealth with that patient, and that can be done when someone is positive, exposed, or has questions on COVID. And that is actually a billable event as well. And so a telehealth billable event could happen in that scenario as well. So obviously that's an additional add-on value that the provider can offer. But it may be that if they're not the primary care provider, then the person may prefer to go to their primary care provider. But the result and the information on what to do is sent to them as part of the test.
Very interesting. And, you know, to think that we have all of these shelters and these congregate care settings where, you know, folks are just, you know, they can't, there is no social distancing. There's only, is the administration or the administrators going to help us, you know, stay safe? And that's why I think that, you know, a laboratory like Beechtree would be really, really of value to municipalities, to states, to systems within those states, because I think that you guys' testings are, you know, the new gold standard. And you really, the profile of Beechtree should really be raised. And that's why I come, you know, when I met you guys and I was doing my continuing education and I saw the way your laboratory analytics was, and then COVID, I mean, to me, it's sort of like, wow, this is amazing stuff. And I would definitely want to try to support it in every way that I can. So, you know, I've been trying to introduce people to you, introduce people like Marty. I'm Marty. And, you know, just bring people to the table, because I think that what you guys are doing is amazing, and that you can really help us get back to what looks like normal.
Yeah. Well, and like I said, the whole prevention, and, you know, you either are preventing something or you're reacting to something. We know we're not a one size fits all, but, you know, programs, you know, Kendra and Laura, we would love to bring everything down and show it to you and just start implementing it. And you guys can actually see how it will work best in your system. But, you know, anybody else that's watching this, obviously we don't know every situation, but I'll bet you we've got a story that will tie to what you're experiencing with what we've already done. And it's a unique, we think it's a very unique solution to a very, very big problem. And so we're just here to help, and hopefully we can fit our Beechtree solution into whatever problems out there.
Mike, I have a question, if I may. In the prison setting, most prisons have a medical facility or nurses that are on staff. Are those nurses qualified to interact with the COVID and the testing and the results and so forth to date? And would that actually generate added income for that prison facility by utilizing the medical staff on the back end, if you will, once the individual is, he's testing positive?
So as a nurse, okay, I'm a
Yep.
nurse. It all depends on your cohort or your color. So for instance, if you're a treatment center, you're paid per day. A daily rate doesn't matter what you do. If you're a clinic, you bill on billable events. I don't know how the prison system gets paid, if it's a daily rate or if it's per event rate. But if a nurse is doing, a nurse can absolutely do this test and run it. The results are then sent to the doctor. If a doctor interacts, it can bill for it. I mean, that's a billable rate, because right now there's really three things that can be billed off of COVID testing: collection, follow-up by a medical provider for like a telehealth visit or something,
Yes.
and then the actual lab. And so we partner with groups all the time that say, hey, we want to be the collection site and collect the money for, I think Chris said it was like $23 per test. Every test you do is $23. It's a collection fee that you can bill. Every time a provider, a nurse practitioner or a PA or an MD, DO, whatever, does a telehealth visit following the symptom, if you even think you're sick and answer anything on the question saying I have a runny nose or something, that generates a telehealth visit. So if you're able to bill for encounters, whether it's a treatment provider or, if you can bill for that, then absolutely those codes are available, and we try and help you out with that. So can it be added revenue? Absolutely.
But have you seen that taking place in Alaska?
So the contracts that we've done in Alaska, Chris, correct me if I'm wrong, they just specifically paid for us to do the testing to go in. We don't know if they billed additional.
Oh, we have a lot of clients who do exactly that. All over the country. Yeah, from Boston to California.
Yeah.
We have doctors in Alaska doing it, right the way to Florida. It's actually encouraged. That the CARES Act, the spirit of the CARES Act is really designed to increase access to testing, vaccination, and treatment. And so it's really expansive in terms of its rules in order to allow that nobody should not be able to access those three things. And that's really important, because if you test positive and you can't access treatment or advice, then that's a problem.
Sure.
And the CARES Act is written to address that exact problem. And it doesn't matter whether you're uninsured, undocumented, Medicaid, Medicare, insurance, whatever, they have to cover it, because the whole purposes of the CARES Act is to make sure that people have access to the care they need during the pandemic.
Thanks, Chris.
Yeah. And treatment centers are scrambling. You have the detoxes, you have, the residential, you have the outpatients, you have medication assisted treatment. I mean, I supervise a medication assisted treatment facility, and what took place was, or is, we only doing dosing. There's no more group therapy. We went from 10 groups to 0. So there's no more in-person services taking place at the medication assisted treatment. All we're really doing is dosing folks. I mean, they come in, get their methadone or their Suboxone, and they continue on with their day. So what we are instructing a therapist to do is to move to telehealth, engage these folks as best as we possibly can, even though as therapists, we know that being face-to-face with someone, seeing their expressions or having closer proximity is what you build the rapport on. COVID-19 has put a wedge in that, has interfered with that. So the rapport is no longer there. It's like talking on the phone to someone. Are you really reaching them? Are we looking at the toxicology results now as a result of less engagement? And what are those toxicology results telling us? Are they doing more fentanyl? Are they relapsing more? What does the science say as a result of the impact of COVID-19?
Well, and we've got all kinds of studies of what compliance and non-compliance is because of COVID. It's really, it just boils down to how fast can people get back into treatment. And that really boils down to how fast can they get the test results so they can feel comfortable to go back, and the facilities feel comfortable bringing them back in. And Chris and I mean, we've been in so many different places to where you can literally show that QR code on a phone and say, let me in. I joked around one time, I'm clean, let me in. You know what I mean? But that code, literally as fast as it comes back, instead of waiting for a result to be interpreted, again, that's the whole reason for the app and the application on your phone to be able to say, I'm negative, let me in, or you can stay in. And we've used it as gatekeeping apps, as passports, whatever you want to call it, whatever you want to do. But it's really, it's giving solutions back to programs or back to entities that are currently trying to figure out how to even test. I mean, or even where to test.
Yeah.
And so that's it.
Yeah, it would also help, administrators of substance abuse programs, outpatient, with medication assisted treatment. It would also give us the ability to begin to start calling clients back into the facility. Like, hey man, we saw your PCR test, everything is good. We want you to come to group tomorrow. And then you can begin to test people like, I had suggested in that 72-hour window to really maintain that sorting out of, who may be positive or negative. And you can start calling people back into the gatherings. We still want to do the other precautions, wearing the mask and washing your hands and stuff like that. But at least we know that we have a negative test for this person that's less than 24 hours old.
Yeah. Because the worst thing is when you finally do get your results and it says you're negative 7 days later.
Yeah. Because I had a guy say today, when he came in, he said, well, I did a PCR test and it was positive and conclusive. And then I did a rapid test, which was negative. And what, we had talked about that earlier, but what really set with me when he said that was, he said, listen, man, I'm just trying to get back to treatment. I'm sitting home and I'm spinning and, I'm thinking about drugs. I need to get back in the circle. And that's what's really happening. What we're doing, we're calling clients and we're trying to engage them. And it's like they're drifting back towards use.
Yeah.
And losing them. And we got to figure out a way to save them. And testing is that way. Testing is that alternative.
Well, can we open up to any questions, or I want to make sure that,
Sure.
Be able to answer any questions that people might have.
No, I don't have any questions, but good evening. My name is Ayadeli, and I'm very close friends with Mr. Brown. We work in the field of substance abuse, and I work for detox and rehab. And just to really piggyback off of what both Mr. Brown and Mike stated, just finding a quicker way in terms of trying to get our patients back into treatment, because I know what we have seen within the last couple of weeks with the increased COVID cases and with the new variant is that there's a lot of false positives. So we may have an individual who may come into treatment and vice versa, who the test is positive because we provide a rapid test for all those individuals who are actually coming in for a face-to-face interview with the hopes of being admitted into the program and meeting the criteria of the program. But then I get a call a couple days later, they went to urgent care or their PCP and had the test administered, and come to find out that they are now negative, So these are individuals' lives that we're talking about, and it's trying to find a way around that. And I know myself, along with administrative, been trying to work together with OASIS to come up with a plan for individuals. I mean, we even talked about in terms of like just having a quarantine area for individuals coming in that are positive, because I know in just 1 week, we unfortunately, because we don't have the space and because of, you know, the regulations, you know, we have to send patients out, you know, and it can be anywhere from 8 to 10 a week, and that's a lot. And as we go through winter, this is what we're going to be facing. And it's like, how can we continue to save lives? Because as we know, previous with the first variant, that, you know, we had a high rate of overdose. So how can we really support, but only, you know, impact in our community to where we can have individuals come into treatment and be able to provide a service to them as well. So I just hope that with Oasis and other leaders, we can really have a discussion around this, because for me, it's all about saving the lives of others, you know?
Yeah. Yeah, and if you don't have the information, then it's hard to make any decision, because you're in a holding pattern until you have the information that you need. The worst thing about labs is the wait time and the time that it takes to get the results back, because you can't make any decisions and move unless you have the results. And so the quarantine area is a really good idea, but at the same time, if it takes 7 days, you can't say that this is one group that came in on Tuesday for 7 days, and this group, you know what I mean? A lot of times you're all together. And so again, kind of before you jumped on, our whole solution is giving you the tools to figure out how you can use what we have to your program. How can it benefit? And because not every program is the same, but we've also found that it's a lot easier when you understand what we can give you and how you can use it than us coming and saying, we're the lab, do it this way. And a lot of times when I'm talking with Thurman, there's a lot of needs. Like I said, every location is different, but some of the buildings that you guys have out there, it would almost be best to say, hey, this is our testing solution in room 2B. Go down there on Thursdays for this group. However you want to use us in your own situation. But the turnaround time and the results, the only thing that we can't control is shipping. Other than that, once it reaches the lab, it's a 24-hour turnaround time, sometimes less. And that information is automatically sent back to you guys. And New York's an interesting location. The second we have a temporary license to work in this emergency authorization, as soon as the state gives us that, I might be meeting you out in New York. There's a lot that we'll be doing out there. We're just trying to get that emergency authorization to be expanded besides just the few companies that they allowed in. So hopefully that happens quick when we come out and work with you guys.
Mike, if I may, this webinar, a few minutes, has really been informative. And I hope that you and Thurman will produce a second one, just a string of them, actually, to keep abreast of all the changes that are going on and the solutions that you continue to find and provide.
Remember too, this is flu season. A lot of people are sick, you know, and it's not always COVID. And some of the things that we're learning about COVID or the different variants and stuff. Chris, I don't know if you're still on. How many different variants have we caught in the lab? I know you're on top of that all the time. But every time we get a positive, it gets sent off to the state lab to identify which version it is. And
every variant of concern we've caught up with, there's so many, but all the variants of concern. So
we have caught
the ones that we're most worried about this year have been Delta and Omicron. And yeah, the Alaska State Lab and the Utah State Labs sequence every single one of our positive samples. So we have confirmation back that we're picking up all of these. You can't get the results. I can only tell you that you're positive or negative to COVID-19. I can't tell you that you have Omicron, even though the state does that for surveillance purposes. They don't release the results.
Yeah, you have to actually contact the state to find out what variant you got.
Well, you can't even do that. They won't give it out. But
they did in September. They're overwhelmed.
Oh, back then, yeah, but now they probably can't. Yeah, but in the Alaska state actually releases if you Google Alaska COVID variants, they actually have a dashboard that they publish every Friday that shows you all the variants that are being picked up in the state of Alaska, and you can see that. And a lot of that is based on the data that we, obviously the tests that we give them. So that's kind of interesting. Not every state does that, but Alaska, I think, does a really nice job of that if you wanted to sort of look out of interest.
To tell your states to do the same thing.
Yes, and one of my goals is to take this recording, and I'm going to share it with Oasis and everybody who will look at it. I'm gonna make it into a YouTube, because I have a YouTube channel, but I'm definitely going to circulate this this recording to the addiction space, because I really do think that they need to understand that there is a way to begin to look at how we can manage bringing people back on site safely by using testing as a way to really sort things out and say, well, you know, well, this person has tested negative within the last 24 hours. This person can come back into the group setting. This person can come back into the individual session, and then keep a testing track of that person moving forward. Everything should be okay with that person. And
yeah, I would add to that, Thurman. I think that's really interesting, because very early on in the pandemic, we talked about this exact thing with a number of our clients, and at that time, most people were doing sessions virtually through Zoom, or had stopped to some degree, which was a real shame. And then I think as the pandemic's gone on longer and longer, you know, that sort of situation becomes harder and harder to manage, particularly, you know, for people in this sphere. And so I think, you know, we've felt really compelled to help our clients, and we do a lot of COVID testing for our clients just to cover that. And you know, when you think that it's covered completely, it's no out-of-pocket cost for the provider or for the patient concerned, then it seems to me like, you know, it's a good thing to do to keep people, you know, moving forward, and as we hope they will in the program. But also the providers, as I mentioned earlier, are actually entitled to bill for that collection process and follow-ups, and so therefore there may be a, you know, an opportunity for them as well in that regard.
And you know, let me just say this, Mike. What a lot of providers don't know is that the CARES Act covered this. It's no out-of-pocket expense to the agency.
Yep.
And that's the word that's not really, you know, getting out to these providers, because they're not taking advantage of, you know, the CARES Act. You're not taking advantage of the one thing that would help you, you know, bring your services back online. There's no out-of-pocket expenses. Go ahead, Mike.
And Marty did mention that these are all billable services, and depending on your location and where you are, some of the programs that we get started with, they kind of take care of their own group first, like their own building or their own program. And then if they have time, then they open it up to the family members, or the, you know what I mean? It's just kind of like, instead of trying to save the world, they just say, hey, no, we're going to take care of our building. And then once our building's tested, then okay, family members or whatever else from our building, or we can go to another building. And so some of these programs are setting it up to where they're taking care of their own people first. That way the treatment can go on, but then they're turning it into a community resource for above and beyond. So it's kind of nice to see how everybody has their own play with this, but it all comes down to, do you get the right information so you can act on it? Actually, objective information is our whole goal.
Because treatment agencies, us treatment providers, we're mostly conditioned to think in silos. It's, you know, it's us first.
No, absolutely it is. Absolutely.
And then once we begin to understand that, you know, this could also be expanded into the community, then we open up the doors to the community. So, but it takes a minute for us to arrive at that conclusion. But hopefully this video will help providers understand, like, hey, the CARES Act is going to pay for these resources. All you have to do is plug into them. And guess what? Why don't you make your site a testing site for the community? Because you are a good community partner. The people in the neighborhood knows you. So not only take care of your folks in your building, but also take care of the people in the surrounding neighborhood.
Well, and we try and be partners with those groups. We like staying in our lane. We're the lab. We're really good at what we do, but we want to partner with collection groups. We want to partner with providers, with programs that do it. And we'll share with whatever information we have to make them successful, because that will make us successful.
Yeah.
We try and be as transparent as we possibly can, because this is a crazy time that we're in, and clinically it's a nightmare. So we're trying to do whatever we can to make it better.
So I definitely would like to have that flyer, because I would want to put it on LinkedIn as well, along with this video. So, you know, folks could really have something to look at. You know, there's you're hearing our voices, you're hearing these explanations, but I think that PowerPoint that Chris was showing is chock full of information, and people need access to that information. And I would love to be able to publish it to whomever would like to look at it.
Well, we're available for you, Thurman. Thank you for putting this together. And anybody that has questions, let Thurman, get them in touch with us, and we'll answer and do whatever we can to help out. We appreciate you.
All right, guys. You guys got any more questions before we put a wrap on it?
And very informative. Thank you, gentlemen.
Kendra, you'll hear from us tomorrow, okay?
Sounds good. So Laura is actually the one over West House.
Okay.
You're welcome to reach out to me, but most of this stuff will go through Laura, but I'm sure we're going to be very.
Sounds good. Either way, we'll make sure we take care of you guys.
All right. Sounds good. Thank you.
Thank you. Thanks,
All right,
everybody.
guys. Thanks for showing up. We appreciate y'all.
Well, good night.
Good night, everyone.
Night.
All right, Della. Good to see you. Yeah, Mike. Oh, okay, good.